morning to all of you. We're continuing with our discussion about oncological emergencies. So, Dr. Nadeem, hyperleukocytosis, we know there is a heterogeneous definition about it. Some are telling 10, 30,000, 50, more than 1.5 lakh, but the consensus is more than 1 lakh WBC count. So, what are the common cancers you see with hyperleukocytosis in your practice?
The commonest cancers, as we see, patient apparently with almost no symptoms and having a hyperleukocytosis that like CML
Yes.
we get to see, and most of the time they don't have much of a symptom. And other than that, we can get to see the patients of this CLL also, and other than that, acute leukemia like AML or ALL. But the thing is that those acute leukemia patients, they are most of the time very much symptomatic.
What are the symptoms of this hyperleukocytosis? Common, which can prompt somebody that he may be having hyperleukocytosis if there is no background history of any cancer.
So, what there is, what you cannot say with a single pinpoint feature that okay, this suggests of a this hyperleukocytosis. But the thing is that there will be, I mean, multiple. There can be just wide variety of a symptoms. So the symptoms will be produced secondly to the leukocytes,
Like?
that leading to the this obstruction of the vessels, like
Symptoms?
small. Like, so the common symptoms which can be starting from the head, this like altered, or one can have a just altered sensorium, or one can have a just headache, and besides that, straight away with the loss of a vision, or just a diminution of a vision.
Patient most commonly can present with shortness of breath also because of the leukostasis in pulmonary microvasculature.
And one of the symptoms what they previously found was a priapism.
Priapism.
Priapism,
Yes.
yes.
These people
Because of the microvasculature of the.
complaint, so should someone focus that this must be hyperleukocytosis. Next slide. Next. Next. Treatment option is what we do in our practice. We give them good hydration. We try to diagnose whether it is CML, CLL, ALL, AML, and treat the underlying disease. And supportive treatment, good hydration. We give them these allopurinol or these enzyme oxidase inhibitors to prevent hemolysis and other supportive care. Then leukophoresis, I don't think how. Nadeem, have you seen this leukophoresis in your setting being done for hyperleukocytosis?
Yes, I do have seen patients presenting. I mean, they were in a quite bad shape. I mean, they were quite sick. Patients with the leukocytosis, with presenting with leukostatic symptoms.
Mm-hmm.
So after giving this basic treatment, then I mean, many a times we even planned for this emergent leukophoresis, but patient didn't survive for that. But in fact, whatever oncology I have practiced, I have never done any emergent leukophoresis. But yes, definitely that remains an option, and that too with a routine pheresis machine. It's not that difficult, like that of a this sample connection. We can offer this leukophoresis.
The idea.
So are we talking about leukophoresis here? I'm sorry, I can barely hear you guys. Are we talking about leukophoresis?
Yes.
Yes.
Okay. Sorry. Trying to increase the
Would
volume.
you like to talk about something like on leukophoresis?
Yeah, so we do that. I mean, I have had to do it a few times, but I try to cyto-reduce as much as I can because, it's typical Friday night or, Saturday night problem is that someone will show up with a white count. Of course, myeloid versus lymphoid makes a big difference. It's a myeloid malignancy. And I'm okay up to 100, maybe 125, 150,000. Beyond that, I get a little nervous. Also, it's symptom-based also. If the person's getting confused and all that, so there's definitely and pulmonary congestion and those things. So leukostasis it's a problem. So we get the leukophoresis done. What else? In our APL cases also, there's a problem sometimes with that. Has had to do it once or twice with that. But it's the APL is such a, you have to just make sure that you're playing the right thing, right time, and titrate everything properly. So it's fine. But usually the CML in a blast crisis kind of a thing that we had to do leukapheresis. Other thing that I've used is, hydroxyurea, of course. We always use that.
Yes.
And Johns Hopkins, I've seen them use cytarabine, low-dose cytarabine, before they, so someone with, so as to kind of put them into the 7+3 or whatever induction chemotherapy they were going to do. But before that, they use cytarabine as an infusion. What are the other things can be done? Yeah.
What about
Of course.
like you talked about this cytarabine? What about the use of this donorubicin? Do you use it? I mean,
You can use anything that's going to bring the DNA down. Will bring it down. It's just that which one I don't remember using donorubicin over. We could technically use them. That's a part of a 7+3, isn't it? So that's fine. Any of those agents will work basically, right? But it's just give a drop, a drop a day. Don't go too fast.
Give a prephase. What we do in these prephase chemotherapy like cyclophosphamide, steroids, and then initiate the definitive treatment.
Right, exactly. Yes, yeah, preface, right. So yeah. So don't hit the gear altogether. Just make it slow.
Yes.
If any role for urinary alkalinization?
Oh yeah. So what do we do? Bicarb, right? Soda bicarb. What is 650? So we do. I am a big hyper CVAD person because my people who train me from MD Anderson. So that school comes, So hyper CVAD, it comes with the methotrexate, the urinary alkalization, all the fun stuff. So that's why I think I kind of know that part fairly okay well. So what is 650 milligrams of sodium bicarbonate? How often do we give it? Every 6 hours, every 4 hours, so 4 times a day by mouth. It's fine. Another thing I do is I usually start them 2 or 3 days before. It's nothing but soda, right? Your common, what is this? The kitchen soda kind of thing. So I start them on the pills 3-4 days before I'm going to bring them to the hospital to give the chemotherapy. So they start getting all nicely alkalized and everything. Okay, so then you monitor the urine pH every 6 hours. So you tell the nurses to do that, make sure the urine output. And that sometimes can be painful to make them do that. It has to be above 7.0. Okay, if it comes down below 7.0, then we hang a bag. I order a bag of sodium bicarbonate, 75 milliequivalents, IV kind of bolus kind of a thing, in addition to what all you were doing before this. So yeah, urinary alkalinization is absolutely a must.
And the next oncological emergencies, which is very important, is tumor
lysis. Yay, I knew that.
Yes.
So we will just ask one question to you. Is there any role of using prophylactic raspberry case?
The raspberry case reps are telling me that there is. Okay, they've been bugging me for the last 1 year now, 6 months, 1 year. They've fed me a lot of good food, looks like, and they just want to tell me that, there's a high risk patients. Okay, so you can tell them by the age, LDH, baseline uric acid, whatever the factors are, and then pretty much that criteria, everyone will fit into that criteria, pretty much. Okay, and then you're supposed to give them prophylactic raspberry case. That's a standard of care now. I don't, because again, people cannot afford it. That's a problem. So if you use your allopurinol properly, you alkalinize the urine properly ahead of, don't, until it's an emergency, and I've used raspberry case as back as almost 10 years, 12 years back when I was, doing a fellowship. Even then I had used it because it was a very experimental drug at the time. It'll bring down the uric acid just like that. But if you plan it ahead well, then I would not go for the raspberry. You keep it, don't have to use it. It's very expensive. Until the cost down.
Cost is issue with us. Yes.
Cost is issue with us. So, but the raspberry case rep is like bugging us every other day. Okay, so everyone should be getting, anyone with lymphoma and everything, they should be getting a prophylactic raspberry case, 1 dosage, I think, and that way everything will be fine. I'm not sure.
See, this tumor lysis syndrome, there is rapid cell death in the face of high tumor burden. We have to find prominent cancers which have a very high risk, like you have acute leukemia.
Yeah, I mean, again, if you planned it ahead, I mean, if you know what you're looking at, and again, that's the art of oncology, in my opinion. So if you know that when you're going to get in trouble, then you do a couple of different things. You start the hydration way before, start the allopurinol, start your alkalization, and then the chemotherapy. Don't give the whole, don't throw the whole bucket at the same time. Drip by drip. I mean, slow it down the first 2 days, and then you can take it off. And even in spite of all of that, if it happens, then raspberry is there. But tumor lysis can be a scary thing, and I know we have not lost anyone to that yet. I think in my 15 years, but it got pretty close. ICU and all the fun stuff happens.
I when somebody develops tumor lysis syndrome, morbidity.
So, but my thinking is, if we did a good studying of nephrology or acid-base metabolism, then you should be okay, I think, with tumor lysis. That's my take on that. All the kids who get in trouble with tumor lysis are the ones who do not know their H ions and anions usually, and they don't what's intracellular, what's extracellular kind of thing. So cell death is going to happen. That is what the plan was. It is just going too fast. So you can do one of those: stop the chemo if required be, fine. When I said plan it ahead, I mean, that's the thing. If we cannot plan ahead of time who has a high tumor burden and who will need prophylactic, I mean, then it is, then we should pay for the raspberry case, not the patient, I think.
Those who are high risk to develop tumor lysis syndrome, we should be very cautious in dealing with those patients.
Yeah, I will start them, right? When I see them, I start them on all the, goodies. IV fluids, sodium bicarb, allopurinol, start the chemo, but gently. I sometimes do just chop, even for R-CHOP, whatever. I just start with the steroid part first, slow, and then go that way.
Next.
Of course. The cytokine release does bother me a lot. I mean, that is the one thing that is I still don't have a good grip on.
About prevention is hydration, giving them allopurinol, very high doses, and alkalizing the urine.
Yeah.
What about your practice? Do you use allopurinol or you use a febuxostat?
Allopurinol. I know. I don't even know that I've heard the name of that drug recently, but I had to look up what is this, because we don't have. I don't know why we don't use it here, but I know allopurinol.
But
300 milligrams.
Trial, I mean, definitely it has been published.
Yeah, I learned. But somehow, how people are rigid about how they do it things. Here, it's all allopurinol.
It has clearly shown, I mean, just equally effective, in fact, rather more safe, this febuxostat.
Yeah.
But
I will try it next time.
But you will be surprised to know that here the febuxostat is being used every left and right.
Say it again.
I mean, very
commonly it's been used.
The front seat instead of.
I know. And I've seen some patients. I mean, some friends of mine with hyperuricemia, and they were given this. I don't even know how to say the name of the drug, but that one. and then yeah.
Now it is treated with this febuxostat here.
Yeah. Sorry, your audio is kind of choppy. I'm sorry, I couldn't hear you.
Yeah, but the dose is, I mean, slightly different. This
of course, 60 milligrams, something like that, isn't it?
40 milligrams.
40 milligrams.
But for this,
I knew it is not 300.
It is this 40 is to be used DID. 120 is the total dose.
Okay. I have a patient right now in the hospital. I just admitted him. Maybe I was there 2 hours back with diffuse large B-cell lymphoma. I think he has a double hit mutation. So we're going to start him on R-EPOC tomorrow. I wrote the chemo orders and came. So I can try that one now. I'm excited to.
Very important oncological emergency is superior vena cava obstruction syndrome. So, Dr. Rashi, in your practice, what are the common cancers where you see this SVC and how it presents?
See, most commonly, we have patients. I have seen only a single patient with superior vena cava syndrome, and he presented to us with sudden shortness of breath, and all the neck veins and the facial veins, they were all prominent. and we started the patient immediately on supportive care along with the steroid, and then we further investigated the patient, and it came out to be this. There was a on CT. There was a lesion in the peripheral location of right lobe of lung. So it was like the CA lung, and on further IAC, it
Like a
was
pan-post tumor, right?
yes, yes.
Hmm.
So yes, it came out to be that, and then we started the patient further on this chemotherapy, and yes, there was superior. The patient got relieved a bit on the third day of the treatment, and after this supportive care, after we started the patient on further therapy for the primary.
So, Dr. Nadeem, what are the common tumors which lead to this SVC syndrome? What you have seen?
But we get to see common here is a lung cancer. It's quite common, and then besides that, one can see even in this lymphomas, and other than that, even breast cancer also there can be seen this SVC syndrome.
There are some non-malignant conditions
Yes,
as well,
but
they're very rare. Commonest is cancer. We have to always think SVC. Somebody has we have to rule out he has any cancer in his mediastinum. So presentation.
Oh, the thymoma kind of thing.
Dyspnea, yeah, thymoma also. Dyspnea, they will present with facial puffiness, edema, upper limb edema, and then there will be these congested veins.
Plethora.
So yeah, we have to try to get biopsy as early as possible and then give patient immediately treatment as per the biopsy report.
Treatment is called the radiation oncologist. Beg them to come in right away and do something.
Yeah, if somebody has small cell carcinoma lung, very chemosensitive, so their medical oncologist's role will come.
Yeah, that is true. But first, the radiation oncologist has to come and zap it.
Predominantly, it is
Then,
an emergency which has to be dealt with radiation oncologist. That is why we started with Dr. Rashi.
Yeah. So yeah, we use radiation first, and I mean, of course, start dexamethasone and all the fun stuff. I have seen once or twice they're putting a stent also because it was, and then radiation.
We could use, but in my practice, I've not used that yet. So yes, maybe that could be an option.
Yeah, I've seen it a couple of times here, but of course, pulmonary does that stenting part of it, and the radiation guys will do the radiation, and I will sit and watch, and then if the patient survives all of this, then come in with chemotherapy.
Patient education that we should try to avoid using any IV line in the upper limbs. That is going to worsen the scenario.
Yeah.
So it should be this message should go to the patients as well as to their caretakers as well as to the nurses. Avoid giving any fluids to their upper limbs. That is what we got this SVC here in this form for education. Next slide.
Sir, I would like to know from you, have you seen those uncommon causes like those benign conditions producing SVC?
I have not seen in my practice.
Sorry, I could not hear that.
But one is in my medicine senior residency, I saw one case of tuberculosis. He had subtle features of SVC, but somehow he expired during his hospital stay. He developed complications. He developed hospital-acquired pneumonia and he died. We could not diagnose. But there was a suspicious of tuberculosis having an SVC syndrome. In fact, I presented it one time.
What about your experience? I mean, at your center, have you seen any? I mean, benign conditions presenting with SVC?
Myself, benign and SVC. No, I have a horribly busy oncology center. So yes, we see SVC like once a week at least, maybe more. Unfortunately, all of these are lung cancers, small cell and non-small cell as well. I mean, just depends. I've seen a Hodgkin's lymphoma with that presentation, a gastric met, but mostly it is that pulmonary, that typical squamous or small cell. What else? Yeah, nice SPC, like a proper blockage and everything. So they have to stent and all that. But that's quite a common, situations. As I say, I'm friends with my radiation oncology friends. Keep them happy. It always happen in the middle of the night. So that's one of the times when we need that. What else? Yeah.
They will have
But benign condition, I don't remember any benign conditions.
They will have a thrombus in the SVC. So, what is your practice of using these?
Thrombectomy.
Should we use it or not?
Yeah. We are good plumbers. So what we do two types of plumbing. One plumbing is they go in and they pull the thing and pull it out. Right? That is the thrombectomy. Right? And second one is to put the dreno in there, which is the thrombolysis, and that is an option too. So that is done, and then they put a stent and then radiation.
It is a tumor thrombus.
Then nothing. I mean, then radiation.
Will help there or not?
Say it again, sorry.
They said that this SVC, there is an invasion by the tumor and it leads to a tumor thrombus. So they are not going to get resolved with this anticoagulants.
No, not in that case. No, not in that. Of course not. In fact, anticoagulation not a good idea at all. What do we do in that situation? I think, again, if radiation helps, maybe chemo radiation combination kind of thing, do that. And if the person's very healthy and everything else looks fine, then you can even consider surgery. Snip, connect together.
But predominantly these SVCs related to malignancies. We should do the imaging on priority, get biopsy as early as possible to start the definitive treatment. And then what you are telling about the intraluminal stent in SVC to ameliorate the symptoms of this superior vena cava obstruction syndrome.
But when there is no thrombus, I don't remember the case. It was a while back, but kind of surprising. I've seen a couple of those. One of my pulmonary colleagues would do that actually.
Yeah.
So maybe he was trying to be Robin Hood or something. Who knows?
So this is an X-ray. The patient having a lung mass, right hilar mass with SVC. Next. So then there are other less common oncological emergencies which Dr. Rashi must be aware, like raised intracranial tension, somebody with a cardiac tamponade, massive pleural effusion, and somebody develops pneumothorax and bleeding diathesis. Predominantly we see in APL. They be present with these bleeding diathesis in emergencies and then subsequently diagnosed as having acute promyelocytic leukemias. Next.
Because of fibrinogens.
Thank you.
We take a break again? We're off again?
Leukemia thing, can you do?
ठीक है 8 बजे तक I'm there.
Metastatic is not there, sir. You directly go to the lymphoma, leukemia, and myeloma. Metastatic leukemias. Leukemias were discussed. Leukemias.
Right. Leukemias. Leukemias mean blood cancer. The term came from leukos and hemia, meaning white blood. Probably the first slide which was seen could have belonged to CML cases, where the WBC count goes enormously high. Whenever we see the slide under a microscope, normally red cells are in millions, so largest component is the red cells. WBCs and platelets. WBCs are in thousands, 4 to 11,000, and platelets, tiny particles, which range somewhere from 1,40,000 to 4 lakh, or sometimes 4,50,000 in certain laboratory setups. Since the WBCs were enormously increased, so the term came out, white blood, that the red blood has been converted into white blood. So this is how the term came out. So a group of malignant disorders affecting the blood and blood-forming tissues of bone marrow, lymph system, and spleen. Here I may add that leukemias originate from the bone marrow. It's a malignancy of hemopoietic system originating from the bone marrow. And if we recall, we have hemopoietic stem cells which differentiate and mature into various cell lines: erythroid, granulocytic, monocytic, eosinophilic, lymphoid, megakaryocytic cell lines, and so on. So accordingly, any cell line being affected with maturation arrest will result into those leukemias. So those will be acute leukemias where the maturation arrest is there, but the leukemias where maturation is allowed or permitted, those will be described as chronic leukemia. So in world of oncology, everything is possible, and therefore age is also not the bar. Although we have certain leukemias in elderly, adults, children, infants, we do have congenital leukemias, but all leukemias can occur in any age group, but particularly acute leukemias like acute lymphoblastic leukemias usually are seen in children. Acute myeloid leukemias are usually seen in adults and elderly. Therefore, the chronic leukemias usually seen in adult, middle age group, or elderly individuals. But here is one of the entities like chronic myelomonocytic leukemias can be seen in children as well, and also one more group which is called as the same one, juvenile myelomonocytic leukemias, which occurs classically under the age of 4 years, and now the recent available data is that more common under the age group of 3 years.
So therefore, these leukemias, what was the scene earlier 10 years ago is not now. It's entirely a change. The leukemias can be diagnosed, can be categorized, and with the help of molecular and cytogenetic information available, we can predict the biological course, treatment strategies can be planned, and we can predict the outcome of the disease. So therefore, nothing to worry. The outcome is very good. Some of the leukemias, particularly ALLs, if treated in a well hemato-oncology center where monitoring of the disease is very well, particularly the minimal residual disease. If it is monitored in a very effective manner, the patient can be cured. At least a prolonged survival is assured, and patient can have during these remissions have a nearly good quality of life. I can say normal quality of life during this period. So,
Professor Poole has already elaborated about the definition of leukemia. I will ask Dr. Nadeem that what are the common symptoms, signs you can suspect that somebody has an acute leukemia and how this public should be aware about these symptomatology of leukemias and how they should be very bothered that some child or some young male or female young adult has not leukemia.
As if we talk about this leukemia, the commonest symptom, if we talk about the acute leukemia particularly,
General public should know.
the commonest symptom is that person may present straight away with the anemia, symptomatic anemia. So the important point to stress here for a general public is, or a general practitioner or a general physician, whoever. So whenever somebody sees a patient have a anemia, don't ask for only HB, ask for a complete blood count. This is one of the very important. It should always be stressed upon. Ask for a complete blood count. And then besides that, the common symptoms, other than that, there can be this patient may present with a lymphadenopathy, or patient may present with this abdominal complaint secondary to this organomegalies like hepatomegaly or splenomegaly. And other than that, one can have a just bony pain. Besides that, one can present with just an infected
There is bone marrow failure.
Exactly.
I think any patient presenting with weakness, with a history of weakness, malaise, fever, continuous fever, without any known cause, with bone pains, bone tenderness, and particularly some bleeding manifestations should be carefully looked into. And leukemia should always should be kept as one of the probabilities.
Somebody has prolonged anemia, schizophrenia, fever, not settling. A general practitioner, a pediatrician should be well versed in that.
may add here that symptomatology or presentation will definitely depend upon whether the patient is having a acute leukemia or chronic leukemia. It's very important. Remember always that acute leukemias, they come with a storm, a very short history. Short history means a weeks or a couple of months. That's it. Patient apparently remains by and large okay just prior to 2 months. But suddenly something happens and the patient deteriorates and he worsens within a very short time. So particularly in these states and in children particularly, if there has been a viral infection previously and then within this month or so develops these signs, one should immediately think of these issues. Chronic leukemias, on the other hand, they are there for months. Patient may or may not, feel any problem because the chronic leukemias has been there. If we talk about CML, if we say that how long the patients usually ask, doctor, how long I was suffering from this, because I didn't know. I didn't notice. Because these chronic leukemias, 5% of cases may be detected by chance. Patient comes for some other disease, but a routine CBC and an alert hematopathologist will point towards that. So therefore, chronic leukemias can be detected. Either patient comes with an advanced stage when the blood has already been there flooded with the leukemic cells, still patient is maintained and remains stable. But acute leukemia will not result. So this is a bit, and then, symptoms. Symptom will depend upon, because the marrow is being replaced by these leukemic cancer cells. So normal hematopoiesis, so formation of normal blood is affected to a large extent. So blood is not formed, meaning hemoglobin is not being formed properly. So features of anemia. Then our WBC system is reversed. Normal is being transformed gradually into useless killer cells, that is leukemic cells. So amongst these is the neutrophils. So neutrophils are our defense system. So our defense system weakens. So therefore features of neutropenia like fever, sore throat, these ulcers, and remember the usual these septicemic pictures or infections which otherwise are seen in a neutropenic patient of other diseases, probably more common in leukemias, are infections at other areas, perianal areas, fungal infections. They are very, very serious in nature. Then platelets. Platelets are a hemostatic component, and this normal wear and tear happens in our body. So bleeding, it doesn't permit. So bleeding disorders can be there. Purpuric spots, epistaxis, depending upon the platelet count. So therefore, all these three components being reduced, and as a result, the symptoms are being present. Sometimes the leukemogenesis itself, it is not always possible to have a cause of fever in such patients. The blood, the urine may show no growth of any organism, but still patient has fever. So this is as a result of leukemia itself because of production of certain cytokines.
Very important message should go from this podium about this presentation of leukemias, acute versus chronic leukemias. But Professor Cole has already elaborated very extensively that acute leukemias have a stormy course. They present very acutely with a short history, whereas chronic leukemias have an indolent course and they may be incidentally picked up on routine physical examination or any routine lab done for some other purpose. So we will also to Dr. Purnima that what is the time duration of acute leukemias in your setup? The usual time period of symptoms and presentation to your clinic of an acute leukemia case.
So in acute leukemia, I think my favorite ones to treat, because it gives you it's most exciting, I think, is the acute lymphoblastic leukemia. So ALL, of course, is the scariest one of all these 4 types of leukemias, and comes on very quickly, mostly young kids, or teenagers in my practice. No symptoms really, a little bit tired, maybe a little bit of mouth bleeding, a teeny bit, that's it. And they always come on Friday evening, by the way. So and you do the CBCs done in the emergency room, and you see a bunch of blasts sitting there. Now looking at the peripheral smear blasts, it's very difficult to tell if they're myeloblasts or lymphoblasts, but you can tell. I think I can tell now. And of course, everything else will go down. The good cells will go down, and the red blood cells and platelets, and there we go. So we put a Grosjean catheter, we do it, and get all the studies done, echocardiogram, start the the tumor lysis prophylaxis, and then start the chemo within 24 hours. Okay, so that I have done, and then I do not do the LP. I do not do the prophylactic. I'm talking about ALL, Burkitt's, that kind of stuff. Okay, so I do not. If there is a leukemic blast count is very high in the periphery, I don't do the intrathecal chemotherapy with the first round. I'll wait, because then there's a likelihood that you may contaminate the track. So give your chemotherapy, and I'll do the intrathecal chemotherapy with methotrexate and cytarabine, right? With the next round. It's next round. Now that depends, but you do need to get a CSF before you start. The reason being, you need to know if there's a CNS involvement or not. If CNS involvement, then again depends on the CSF fluid involvement or the meningeal involvement. Meningeal involvement, radiation. If no meningeal involvement, just CSF involvement, then you do the therapeutic intrathecal chemotherapy, which will be twice every cycle, versus prophylactic will be once every cycle. And I love hyper-CVAD methotrexate combination. So that's what high dose methotrexate. That's what I do. That's the ALL treatment. Wonderful cure rates. We have very good survivors. I mean, again, I said AML will be a little bit longer. So just think that ALL is the worst one, then AML is a little bit, and even ALL, the T and the B are two different things. They're two different animals. I think I'm more scared of pre-B ALL is my nightmare. I mean, I don't like that one. It's very difficult to. The T cell ALL is not that bad, actually. Okay, so coming down to the AMLs, in the AML, the APL is a different animal altogether, right? We all know that. And that is mostly because of the two main problems. One is the bleeding or the hypofibrinogenemia or dysfibrinogenemia. And second one is the retinoic acid syndrome, or what do you call that? I'm forgetting the the de-differentiation, right? So it starts differentiating. So that's the cell starts going through a pathway, and the APL syndrome. So those two things are the pathognomic of APL. But other AML 7+3, I mean, usually, but they have AML will go on for maybe a month or so, be okay. But ALL is.
Your patient is usually present late, and they are very high.
Always. I mean, there's no way of.
They are earlier picked up. Here they will be treated at peripheries by general practitioners. Sometimes they don't ask for CBC. So
No. You cannot do. Okay. So this is not. I'm sorry. I'm very, very big on screening, prevention, all the fun stuff for breast cancer, lung cancer, cervical cancer, leukemia. No screening. Not possible. You can do a CBC every day on every single human being. The day the leukemia will come in, there's no way to predict. So there's no point of that. You can do, so here in this country, actually, my children, I mean, and myself, they don't do a CBC on me. When I go to doctor once every 2 years, even then they don't do a CBC because it's not required. So, guidelines, whatever. So point I'm saying is that it always be symptomatic, but leukemia is such a rare thing. If you look at the big public health, point of view, and it's an accident at the genetic level at the person, and there's no way of predicting, okay, I'm going to have an accident tomorrow or day after tomorrow. There's no way of saying that. And there is okay, fine. Let's say there's a screening technique. You find it early. Then what? Are you going to treat it? With what? Are you going to treat the same 7+3 or less? I mean, so there is no, it's getting too confusing now. So there is no way of preventing a leukemia if it's going to happen. It's like that the lightning bolt hitting your head twice. If it happens, it happens. If it happens, dekha jayega. But there's no way of,
I will add one thing here, that in chronic leukemias,
that's a different story.
At least we can suspect quite early, before any elevation of WBC count. Well, a lot of research has been done, and on the basis of the knowledge gathered over the years, I will now say that in CML, a normal patient coming for some other purpose for the hospital, and the CBC by and large shows normal, but there is 2% basophils. Patient is in the range of 25 to 50 years. Well, should we leave this 2% basophils unattended? Should we ignore it? If I am there, I will not ignore. I will first rule out the other causes of basophilia. If I have done that, there is no secondary cause, I will immediately ask for BCR avulsion fusion. And if it is positive, then patient is detected right at that moment with just 2% or 3% of basophils without any raised or elevated total WBC count, no immature cells, nothing at all. This is one.
But will this person meet the criteria of leukemia though? Because the same question comes up in a condition called chronic lymphocytosis of undetermined significance.
Yes. In CLL, if patient is in that range, elderly individual, above 55 years of age, and if there is lymphocytosis merely just around 4,000 or 5,000, I will definitely think of this issue because, and even the age group below that, simple lymphocytosis with presence of smear cell, I will immediately think of this issue because monoclonal B cells have been seen present over there for years before CLL first presents as a diagnostic feature.
Right, so, but that is stage 0 CLL. I mean, it's going to be CLUS, then it's going to become stage 0 CLL for many years. My question is this: what are you going to do with it?
No detection. I am thinking, or I am telling that how to suspect. Otherwise, we may miss these cases. Already.
But what's the point of diagnosing the patient with what's the point? I'm sorry, but I don't understand. What's the point of diagnosing the patient with 2% basophils, or let's say 6,000 lymphocytes per ml? The DL of blood? White count is 11.5. Okay, so this is a chronic lymphocytosis of undetermined significance. Okay, let's say the white count has become 22,000.
Let us be sure. First, we talk about CML. Then we'll talk about
CML is different story. CML is entirely. I mean, I think it's a big problem.
Basophils. Would you leave basophils 2% unattended?
I will look for other causes of basophilia.
Yes, I told you. First, we have to rule out the secondary cause of basophils. If we have already ruled out there is no underlying secondary cause, then what is the line further?
So we're looking at the myeloproliferative disorders essentially. So we'll do the.
Point. So merely if an alert hematopathologist is there, he will not ignore this 2% basophil. This is my point. Similarly, an elderly age group person showing mild lymphocytosis, and if we see a few smear cells, you see, telltale stories are there. Because if we see, say for that matter, acute leukemias cannot be detected earlier and cannot be detected under light microscopy and cannot be subcategorized very neatly. But therefore, light microscopy, I think, is still a cornerstone. But provided you have a knowledge, you have a suspicion for these subtle findings which can catch these diseases quite very early when the main features are not present in the peripheral.
And then do what with it? And then what do you do with that information?
Yes, we'll detect them.
Then what happens? Then you can tell the patient that you have a pre-leukemic condition maybe, or you have leukemia, Okay, let's tell the patient. Then when will you start treating the CLL anyway? Not at that stage, right?
I think information first, diagnosis first is important. Then whether you can do anything or not, that is a different.
That is true. That is true.
But
But that is what.
diagnosis cannot be missed. This is my point. So we have a thing where these cases can be detected much earlier, at least in CLL and CM.
Yeah, moving ahead, I'll ask Dr. Rajat, that what are the routine investigations that are done in a leukemia case?
The most important and most informative and the first investigation is definitely the complete blood count. Okay. Any patient presenting with clinical symptoms already discussed, first we have to do the complete blood count, the basic investigation, the hemoglobin, the total leukocyte count, the differential leukocyte count. Differential leukocyte count gives us a fair picture of the etiology from which the patient is suffering. Though there are some cases where there may be subleukemic picture, or what we say subleukemic leukemias and aleukemic leukemias, in which you have to you are not sure whether this is leukemia or not, but still in our setup the peripheral blood film is the most informative investigation. And further on, after peripheral blood film, then you can decide whether the patient needs bone marrow or not if you are suspecting a case of leukemia. Because many times the initial picture is that of a pancytopenia, and leukemia should always be kept the first possibility. And after peripheral blood film, we'll go to the bone marrow examination, because the final diagnosis is made upon bone marrow examination only.
On PVF, you diagnose that there are blasts,
Yeah.
which is acute leukemia.
Sorry, can you speak up? Sorry, can't hear you.
On PS, peripheral smear, he has diagnosed there are blasts and it is acute leukemia. And now, what are the special tests you will do in the once you will go for bone marrow?
First,
Acute leukemias.
first of all, the light microscopy. The light microscopy examination of bone marrow. We can make
But
a
once you will go for bone marrow, what samples you will take in that go only once you will do for first time, because it's an invasive procedure. Once you will go for bone marrow, what are the tests for the tests you will take the bone marrow sample?
in the bone marrow, we can do the bone marrow aspiration. Then we can make imprint smears along with the bone marrow. And in some cases, wherever there is a dry tap or where there is a fibrosis of the bone marrow, we can go for trephine biopsy also. Furthermore, the bone marrow sample can be subjected to further special investigations like cluster differentiation, the CD markers, which are nowadays the most important modality for making a diagnosis of acute leukemias, especially if you want to make a diagnosis of pre-B cell, pre-T cell leukemias. Furthermore, like in chronic leukemias, chronic myeloid leukemias, the genetic abnormalities, the chromosomal abnormalities, they can be detected in the bone marrow sample.
Continuing with Dr. Rajat, because bone marrow is an invasive procedure. When somebody is on PS, there are blasts, we have diagnosed with an acute leukemia. Once we go for bone marrow, in the same setting, we should take samples what Dr. Rajat has already described. We should take for aspiration, touch, and biopsy, and we should take sample for flow cytometry as well as for cytogenetics. But he was telling about chronic leukemia. These bone marrow samples also for acute leukemias for risk stratification, both in ALL as well as in AML, and then molecular studies.
Right.
Diagnostic dilemmas are always there, and I'll go back to the peripheral slide when pancyte in situations like low count, and particularly in situations where there is pancytopenia. Pancytopenia means where all the formed elements, WBC, RBCs, and platelets. So hemoglobin is low, platelets are low, and even the WBCs are low. And in a situation of pancytopenia, when you hardly see a blast cell, if it is of acute leukemia case, as has been said, that it could be aleukemic leukemia, where hardly any blast cell is seen. Subleukemic leukemias can be suspected easily because the low count is there, but there are a significant number of blast cells. So the diagnostic problem is not there. But the diagnostic problem is definitely there, particularly in some patients who want to go to higher center when they hear about pancytopenia or something. But the clinician has to refer it. So what will clinician write? The diagnosis for referral. So clinician usually comes and asks to the pathologist, doctor, it is pancytopenia. Now, is it aplastic anemia? Is it acute leukemia? Is it anything else? Because pancytopenia, in absence of blast cells, the diagnosis can be 1, 2, 3, 4. So, in those situations, how a pathologist should guide the clinician to at least that no, it is not aplastic anemia. To my mind, it could be acute leukemia, or it could be anything. So, therefore, how to see the peripheral smear in order to at least differentiate aplastic anemia from aleukemic acute leukemia. So I think this is very vital. So what you will think in that situation? If I am there, to remember always, absence of everything in the slide means aplastic anemia. Presence of something, particularly in the situation of pancytopenia. If you happen to see a nucleated red cell, I can say that it is not aplastic anemia. It is some cellular marrow, most likely acute leukemia. So just merely seeing a nucleated red cell in a situation of pancytopenia, where there is no leukemic cell, but one can suspect at least that one can rule out the possibility to a larger extent. It may not be true in 100 by 100 cases, but in large majority of the cases, and clinical details, absence of organomegaly, pancytopenia, nucleated red cell. Organomegaly, pancytopenia, absence of everything will indicate aplastic anemia. I said presence of anything will rule out aplastic anemia and indicate some others. So whether there is organomegaly or whether there is pancytopenia with a nucleated red cell, it will rule out aplastic anemia, which is very important. So as far as the clinical judgment is concerned.
Dr. Nadeem, Dr. Rajat has done 2 bone marrows. So in one, he says that it's acute lymphoblastic leukemia, and he has already taken sample for post-cytometry cytogenetic molecule. So this case is an acute lymphoblastic leukemia, and this flow is suggestive of pre-BALL. The child is 6 years old male. How will you counsel the family about the treatment and prognostication in acute lymphoblastic leukemia, what we say ALL?
Okay, besides this flow cytometry, I would like to know the cytogenetics also.
Already they have done cytogenetics.
And if cytogenetics, if it is not, there is no MLL gene rearrangement, so one can say definitely with the, especially in today's era, that the cure rate is.
Counsel the family.
Yes, I will counsel the family that the outcome is very good and the cure rate is quite high. One can say in today's era, the cure rate is as high as even 85%.
So that cure rate is predominantly seen in West. So what is our cure rate? What is your practice?
Yes,
Cure rate is in our
in
setup.
Indian scenario, if we talk roughly, we can say around about 60% is the cure rate.
Yes.
So, how you will treat an acute lymphoblastic leukemia, and for how much time? What is the duration of treatment in acute lymphoblastic leukemias, and what regime you will be comfortable?
The common regime which we practice here is all this PFM protocol. So the whole treatment will last for around because one important thing is that at the outset the counseling should be very is very extensive, and it should be quite stressed upon the exactly patient's attendant as well as patient should know the duration of the complete treatment, because the default rate is very high, and especially when the patient goes into remission, the default rate is very high. In between, patient thinks that I am absolutely okay, so there is no need to continue with the this maintenance therapy, and they default. So the most important part is that the counseling should be quite extensive, and it should be quite in detail. So the whole treatment will last for, you can say, around 2.5 years,
Yes.
2.5 years to 3 years.
Prolonged maintenance. Dr. Purnima, what is your commonest regime you use for ALL in pediatric population?
I am biased and I love hyper CVAD high dose methotrexate combination.
Okay, quite
So,
toxic regime.
yeah, it's alternating, right? Remember, so
Yeah.
that's hyper CVAD would be, your cytoxin, vincristine, erythromycin, dexamethasone, and that will alternate with the high dose methotrexate.
Yeah.
So it's given every 2 weeks. You have to maintain the intensity of the chemo. So no matter what the ANC is or what, you gotta be very brave. And then I told you, we will do the therapeutic intrathecal or prophylactic intrathecal. So let's say this person does not have any CNS presentation. So then it will be, now check the Philadelphia chromosome, of course, and that will make a huge difference in what else can be done, what else needs to be done, right? So, yeah. And then, of course, transplant or no transplant. Again, see, I'm an adult hematologist, right? So in our world, I think now, transplant is always a situation. But first of all, put the leukemia in remission. And you do that with one cycle. It says part A and part B. So hyper CVAD, high dose methotrexate is one cycle. Get done with that. And then the disease, and then do a bone marrow biopsy. You should not have more than 5% blasts in the bone marrow. If there are more than 5%, even for me, I think I go with 3 to anything above 3% blasts still in the bone marrow. I get really worried about residual leukemia in there.
So Dr. Nadeem has started a patient on his BFM protocol, BFM ALL protocol. So after 8 days, he wants us to do a CBC for PS examination to Dr. Rajat.
CBC for what?
Rajat look into his PS at day 8. And is that any bearing on the prognostication in ALL?
So in the peripheral smear after the regime has started, basically we have to look for the amount of tumor load, the number of blast cells, whether the regime has led to any decrease in the number of blast cells. That has a significance on the further therapy to the patient.
Yeah.
Usually,
We do the day 14 bone marrow, right? So that I still do the day 14 bone marrow.
Mostly the repeat bone marrow usually done on after 2 weeks of therapy, and we have to look for the number of blasts. Usually the blast count should be reduced, or almost if the patient is responding well to the therapy, we expect the blast count to be reduced to minimal amount, especially in the peripheral smear.
True.
And
peripheral smear will get cleaned up in 2 days.
Yeah.
You start hyper CVAD, day number 3, everything is clean.
Actually,
I've treated quite a bit of ALL. I've never seen any ALL not respond to hyper CVAD. The problem comes with recurrence, or the relapse. That's a different story altogether. And I'm still trying to, there are a lot of techniques to do what to do then.
the minimal
But putting
residual,
inhibition is not a big problem. It's lovely, it's easy.
we have to be cautious about the minimal residual disease, especially. And that minimal residual disease is the major dilemma because it is usually not diagnosed on peripheral smears. And for minimal residual disease, we have to go beyond bone marrow light microscopy findings.
Oh, yeah. You do it, you do it with RT-PCR, right?
And it is one of the major reasons for recurrence occurring in patients, recurrence and
Of course.
relapse.
I mean, you want to eliminate every clone possible, and if it's not eliminated, then it will come back.
Yeah.
I think first bone marrow examination after chemotherapy cycle will determine how the patient will behave. So it is again the number game, the number of blasts. What is the quantum? So if we call it a hematological remission, it should be always less than 5%. Then the patients are a candidate by and large, which will behave very well in future. But if it still remains elevated, more than 5%, probably such patients may not behave very well in future. So therefore, this is a vital thing that first bone marrow after the cycle. And if yes, we have to be very cautious that the blast should not be confused with the hematogones. One has to be very sure so that we don't include hematogones with the lymphoblast. So that is a very vital issue here while assessing post-chemotherapy bone marrow.
But we do flow cytometry. The flow cytometry blast has to be less than 5%, I believe, 5 or 7, I don't remember. And the microscopy examination, it has to be less than 3%. The flow cytometry is much more sensitive.
In peripheral smears, along with the blast count, we also have to see for the platelets. Usually, if a patient is responding well, the platelet count also rises more than 1 lakhs. And then the absolute neutrophil count also is more than 1500.
So second patient, Dr. Rajat gave a diagnosis of acute myeloid leukemia. How you will treat an acute myeloid leukemia in a patient who is 60 years of age, having a good performance stats? How you will counsel the patient, his family, and what are the treatment decisions? He has done cytogenetics, he has done molecular profile. So how you will risk stratify acute myeloid leukemias and what are the treatment options available?
Acute myeloid leukemia is to be risk stratified as per the cytogenetics. We have to look for whether the cytogenetics is a good, normal, or a bad one. So after risk stratification, obviously, more higher is the age, so higher, worse is the outcome as far as AML is concerned. But if patient has got a good PS, one can still go with this curative intent. But again, there will be a high possibility of a relapse, and another possibility that there can be possibility of even drug resistance. Yeah. Because higher age, the higher the chances of the drug resistance. So I will say to the patient as well as to the attendants that the cure rate will be slightly low if we compare it with the ALM. Yes. So we can say roughly around say 25 to 30%. Around 30%.
So and also I'll add here the associated components while diagnosis of AML has been given. This is very important. One should not ignore that whether AML is also showing significant dysplasia. So AML with multilineage dysplasia is a entity which will not be cured very well. The behavior of such patients will be bad because these are the ones who have evolved either as a result of a pre-leukemic or a myelodysplastic situations or probably from secondary, what we call the secondary leukemia, where patient has received some kind of chemotherapy, some other purpose, and now they are the ones. And these patients often show complex cytogenetic abnormalities, and they are not, in any case, favorable patients for the oncologist. So therefore, these issues have also to be kept in mind.
Dr. Purnima, what is your experience of using 3-7 in adults vis-a-vis children? You give 2 drugs of 3-7 in adults as well as in children, or you have a different regime? You treat AML in children with a different regime?
I don't treat, I don't do pediatrics. Sorry. So I don't know what they use. I suppose they use the same thing. Yeah, I think they do. But I use 7+3 all the way. I said that, if someone's healthy up to 80 is okay. In fact, there's a literature saying that you should not undertreat elderly just because they're old, the number. So beyond that, otherwise 5+2 and the other option there. I have not done any pediatric, we cannot do pediatrics since I'm not a pediatric. I'm into medicine.
You will be comfortable with giving 1 induction 3-7 or 2 inductions?
Depends upon your blast, depends upon the residual blasts, right? I have done the back-to-back 2, or I've done 7+3 followed by 5+2. Yeah, maybe needed. I actually done.
Trial is going on that giving 2 inductions with 3-7 is going to achieve longer these CRs and better cure rates. But in our setup, we are even struggling with 1-3-7.
Again, I don't know why. They do these clinical trials mostly in Germany or at MD Anderson.
Centers are also part of that trial. One is Alne Institute of Medical Science and second is Adyar Cancer Institute.
Yeah, but the question is this: the more chemo you give, if the leukemic clone is responding to that chemo, okay. So of course you give this much chemo, it will go down. You give a little bit more, it will go down further. But are you eliminating the clone completely with the double tandem chemo, so to speak? No, you cannot, because you still have to go and do the transplant or give some sort of maintenance treatment. I feel that 7+3 followed by one of these TKI kind of maintenance is a smarter thing to do. You can hit a young person with 2 back-to-back 7+3, but the same thing is multiple myeloma. You can bring the clone down, but this level becomes 0. So,
any upfront your experience of using upfront targeted drugs in acute myeloid leukemias?
Like they do that with the FLT3 mutation. They do that. Yeah. Sorafenib.
What is the current status of sorafenib?
Right. I'm sorry, I didn't understand that.
What is the current status of using sorafenib upfront in these FLT3 ITD mutations?
I have not done that myself. I'll say I don't feel very comfortable. I'll just do 7+3. And or if but with your ALL with the Philadelphia chromosome, then I will use an imatinib kind of a thing, or one of those newer imatinib, so to speak. But upfront sorafenib, that is still a clinical trial thing.
So, but what we gather from this discussion that in ALL, good risk chemotherapy is the standard of care as of now. Whereas in AML, those who are high risk, giving them chemotherapy and subsequently once they achieve CR, they should go for transplant. Whereas in low risk, standard risk AML, we have to give chemotherapy. Intermediate, there are some conflicting reports whether to go for transplant or not to go for transplant.
Right.
So, another question is to Dr. Nadeem. What are long-term complications of treating acute leukemias? Children, especially.
Long-term complications taken later develop just patients of ALL, giving them chemotherapy later makes them prone to even developing this AML also. One, and besides that, one can develop even this secondary MDS because of this. And other than that, they are also prone to malignancies also.
But whatever the long-term side effects might be, this is a deadly condition that you will not.
Toxicity, like their development milestones may be delayed. They will have long-term CNS toxicity, then gonadal dysfunction. I want to ask Purnima, Dr. Purnima, about what are your these procedures you do for fertility preservation in your setup in these pediatric leukemia patients.
We have done both the sperm preservation as well as oocyte retrieval. Those are the only two. I mean, that we send the patient to a center essentially, and they do that. I have treated a post-transplant induced cardiac transplant patient, 18-year-old. So that was the most youngest one that I treated with Hodgkin's lymphoma. That was a PTLD, a post-transplant lymphoproliferation disorder, and that guy we did the sperm, preservation, and then give the chemotherapy. And of course, these people, some of them will recover their fertility, so to speak, particularly the younger ones. But it's best to go ahead and store it.
My question to Dr. Rajat: is there any role of follow-up bone marrow when somebody has achieved CR? He is on follow-up. Is there any role of doing follow-up bone marrows during their routine follow-up care when they have achieved CR and they are cured?
Follow-up bone marrow is important because sometimes we may find patients presenting with secondary leukemia in response to the therapy. And that was the question I was in fact going to ask you. How is there any difference in treating a patient presenting with a primary leukemia or a secondary leukemia? Suppose a patient diagnosed with some form of acute or chronic leukemia later lands up, suppose after 4 or 5 years or even 10 years with a secondary leukemia. Is there a different treatment protocol, or we will again continue with the same treatment which the patient has earlier been
The
given?
question is, when the acute leukemia patient has achieved complete remission, what is the role of bone marrow examination? I think this is. So the secondary leukemia or primary leukemia will not come here. Patient is already either a primary leukemia or a second. You see, it will be extremely a rare situation when an acute leukemia patient who has achieved complete remission has landed up into some other disorder, particularly the myeloproliferative disorder. Well, here is that situation which comes very extremely rare. The acute lymphoblastic leukemia we have seen have achieved complete remission, was on follow-up, and for several years he did not show any signs of the disease. But later on, after 10, 15 years, the patient has landed up into polycythemia. So patient is on follow-up. Those situations are extremely rare. Those are cases. But the question is, if the patient has already achieved complete remission, and in this situation, if the blast percent or less than 3% have been documented earlier, so patient is hale and hearty. So what is the role of bone marrow examination? Is that your question? Well, it cannot be clearly said. If at all we have to, you see, bone marrow examination to predict acute leukemia or a relapse, for that matter, what I understand, that if at all there is a relapse, then how early we can pick up the disease. And the only situation where we can have this information is the bone marrow. Well, I'll tell you that detecting acute leukemia in that very stage, bone marrow is a crude examination. It should be a doctor in pathology who entirely is focused on acute leukemia bone marrow to predict any subtle change more than 3%. Otherwise, I think for me, even the blast percentage goes up to 2 or 2.5%, I will suspect that case. Otherwise, blast percentage, if you have a thorough myelogram of 1,000 cells, I think we have done our job. If it is 2% or less than 2%, I'll say go ahead.
So we can say that there is no role of follow-up bone marrow examination somebody has achieved CR and he's cured. My answer to the question asked by Dr. Rajat, there is any difference between primary and secondary myeloid leukemia treatment? There is no difference, but secondary myeloid leukemias are usually high risk. They are very disease resistant, refractory disease, and if somebody achieves CR, you should go for transplant if he is CR. Otherwise, they are treated on the same line of primary myeloid leukemia. So we can